Welcome to Amplifying the Patient Journey, a series in which we speak with both providers and patients about the clinical journey with a neurologic condition and what recent advances mean for patients, their providers, and caregivers. In this episode, Billy Irving, project editor with Practical Neurology, interviews Dr. Chantale Branson, Associate Professor of Neurology at Morehouse School of Medicine in Atlanta, Georgia, and a researcher working on the pivotal PD generation study, which aims to improve treatment options through the identification of clinically relevant genes linked to Parkinson's disease. Dr. Branson provides further context for the social barriers faced by people of color who have Parkinson's disease.
Dr. Branson, thank you so much for doing this interview. How long have you been treating patients with movement disorders and Parkinson's disease?
Thank you. Thank you for having me. Greatly honored to be here. I have been doing this for a little over 10 years. I had to go back and check the numbers. That is a combination of the clinical work and the research that I've been doing.
So did you start off with the clinical side?
I actually started off with more of the research. I started a lot of this research looking at racial disparities in Parkinson's disease and how do we eradicate this within the research infrastructure as well as in the clinical realm when I was in training, actually. And of course, I went on to obtain fellowship in movement disorders and sleep medicine with an emphasis with the research looking at Parkinson's disease and help decreasing the delay in the diagnoses and treatment of people with Parkinson's disease. Well, a lot has changed over the years. It is still primarily a clinical diagnosis, meaning it's based on a number of different types of symptoms. This doesn't mean everyone will have those exact symptoms, which I'm going to describe shortly, but I like to start with that. There's no two people who've experienced Parkinson's disease the same way, okay? But the symptoms, we can start it as a mnemonic of TRAP. So T meaning tremor or shaking, is rigidity, akinesia, meaning a lack of movement. Bradykinesia is like slowness of movement, which is the same. And then P for postural stability. And typically, the only thing we really need is that bradykinesia or that slowness of movement. You don't have to have a tremor to have a diagnosis of Parkinson's disease, and alternatively, a tremor doesn't definitively say this is Parkinson's disease. So I know that most people, particularly in the community and within the research world and medicine, we learn a lot about the resting tremor that the person has, and that's the first thing that kind of sticks out. But among newly diagnosed patients, 25% of them may not have a tremor. And we also look at supportive criteria, meaning one side is typically affected more than the other, meaning there, again, that resting tremor and progressive disorder slowly, not rapid progression, slowly. So a little bit over 5 years. So if it's less than 5 years or within 5 years, we start thinking about something else. So those are supportive criteria, but again, another one is responsiveness to a medication called carbidopa-levodopa. Levodopa is the dopamine that kind of help increase that in the brain. There's a decrease in people with Parkinson's of the dopamine in the brain, the substantia nigra, and we treat that by giving them a medication for it. Some people may not respond to levodopa, though. 10% are known not to respond to it, even with a diagnosis of Parkinson's disease. So it is more of a clinical diagnoses with an understanding that some people may have certain symptoms while others may not. And over the last few years, we have developed, or not developed, a new option, call it DAT scan. And this is like a dopamine uptake transporter, and it helps determine approximately, it's not perfect, but approximately how much dopamine is in the brain. The accuracy is also not 100%, like something like an MRI. If a person has a stroke, that's pretty definitive. The accuracy within the DAT scan is about 80%, which is almost equivalent to having an MDS, Movement Disorders Society specialist, such as myself, diagnosing someone with Parkinson's disease. So it's not 100% accurate, but it has come along in the last several years and helped with diagnostic testing with those who don't have access to an MDS specialist in their community. There's also skin biopsy. There's all that people look at. There's alpha-synucleins, and people can do a skin biopsy to kind of help determine. But again, the accuracy of some of these testing and diagnostic features decrease, as well as, just to add back to the DAT scan, with the DAT scan, a person can have a negative DAT scan because over time, as we get older, we have a higher risk of developing Parkinson's disease, but then they can develop symptoms and the dopamine levels change in the brain. So the DAT scan then may turn around and become positive. So even if it is negative, that doesn't mean they don't have Parkinson's disease.
And is it difficult to distinguish Parkinson's disease from other movement disorders?
It varies. It can depend on, again, how advanced the disease is or the progression of the disease. If the person has new onset Parkinson's disease, it can be a bit of a challenge because often when we're talking about bradykinesia, we're talking about slowness of movements. You can have slowness of movements with arthritis or other very typical features, but often we add that diagnostic clinical symptoms into the mix, meaning there may be some rigidity. So we evaluate for the stiffness in the hands or arms or in the head or legs as well. That can help determine that. And sometimes we have to follow people over time to kind of determine if they have more of that. We can do additional testing evaluation to rule out some aggressive form of arthritis and things of that nature. So that would be one way to kind of rule out the potential another cause of it.
And you mentioned that your background was in healthcare disparities. What kind of barriers do Black patients in particular face in being diagnosed and treated for Parkinson's disease?
There are many challenges that people of color, Black, who identify as Black or African American have. And that main challenge is understanding that there is a diagnosis of Parkinson's disease. We've learned through papers. I did a paper looking at a systematic review of racial disparities within Parkinson's disease, that some people identify or believe that Parkinson's disease is just a part of aging or getting older. And often they don't realize that this is a disease process. Other problems include the fact that, unfortunately, as certain people get older, they may lose a loved one. It's usually the loved one or family member who notices the changes and alert the significant other that they're having these particular changes, and that person may not be there for people of color. And then you also have other disparities with respect to just access to care. There's a higher percentage of people who will be diagnosed with Parkinson's disease among people who are seen by movement disorder specialists as myself. This requires a referral from the internal medicine doctor. So if the internal medicine doctor isn't alerted by the problem, because it's not typically associated with a memory problem or thinking problem, it's more movement, and therefore movement can sometimes be diminished, or people just may say I have more important things to do, or just not even think that it's a problem to the point where they'll bring it up to their primary care doctor or provider, and therefore they don't get that extra step of referral to that movement disorder specialist who have that conversation about what this could potentially be.
Do the barriers that exist in Parkinson's disease match those that exist within healthcare more broadly?
Correct. Yes, that does include a lot of the different disparities. What I will say when we're talking about disparities, there's a clinical side and a research side. And what we've done in some of our preliminary evaluation and testing, doing survey studies to people who identify as Black or African American and women, is that they aren't asked to participate in research related to Parkinson's disease. So from a clinical perspective, yes, I think it is a part of the wider understanding of just health inequity and disparities within practicing and seeing patients. On the research side, I think there's a little bit of a difference with that compared to heart disease or stroke care or management and things of that nature. A lot of that research is very aggressive, very, very upfront. The research that we do, we don't often target certain groups or populations. And while I'm not saying there's an ethical line here, we just want to make sure that the research that we're doing looks similar to the population that we're in, the community that we're in. If we have 13% who self-identify as Black or African American within a certain community, ideally the research kind of should reflect that. Or if there's a certain percentage of the population that will have Parkinson's disease versus another percentage, you want that group to be participating in research so that we can have an ethnically diverse group of participants.
Would you say that currently the population that's participating in these studies does not reflect the wider patient population?
Right. The populations in the past, and unfortunately sometimes even today, are often do not represent a basic patient population, participants, or just people who live in the community. And we see that a lot within certain areas and regions. And when I say target, I don't mean target certain areas, but I mean to offer the participant to be a part of it, but also having a conversation. There is a history behind the reason why there's skepticism with respect to research within the Black community. There is a long history, and I could talk for hours about that in itself when we're talking about the Tuskegee experiment, Henrietta Lacks, and I can go on and on. And what we have to do is have those conversations and acknowledge it. Instead of just saying, hey, do you want to do research? We want to make sure that we have a population that is reflective of that particular research so that we can have a better understanding of the community as a whole. And having that understanding of this is why we're doing it, instead of people feeling like they're a guinea pig based on the history, and understanding that things have changed. It's still voluntary. No one has to participate, but these are the reasons why we want to include you into this research. And often we see that many people are really supportive and on board to participate in this research. When we're talking about this research, we have developed, Morehouse School of Medicine has partnered with the Parkinson's Foundation to work towards bringing awareness to various disparities that I've spoken about here so that we can make it more health accessible. And the Parkinson's Foundation, along with Morehouse School of Medicine, has created new tools for the Black Parkinson's disease community. And we've hosted in-person events for the Greater Atlanta area at Morehouse School of Medicine and at the local Atlanta, within the local Atlanta community as well on the local level. And our hope and goal is to further the foundation's reach on a national scale to everyone.
So pivoting now to the PD generation study, would you tell me a bit about how this study addresses some of the barriers you've mentioned?
As a clinical research scientist, the first thing I wanted to do upon joining Morehouse School of Medicine was join the Parkinson Study Group, which is the PSG cohort, looking at research around the world, but particularly in the United States and 2 places in Canada. And what happens is we have these opportunities to participate in various different research, and PD generation really really was a focal point for me. I wanted to participate because it was a little bit different from the other research that we do. All research is important. We do things from survey studies to clinical trials with respect to medications and other things of that nature. But this was a gene study where you not only receive the results of your genetic testing, you also receive genetic counseling. So the results of the genetic testing provide the gene study, PD generation. They look at 7 genes. They help determine if the person has these particular genes. They give them the results and they go through genetic counseling. So that's why I thought it would be great for us to partner with the PD generation study and the Parkinson's Foundation. This idea of we're providing results is not common, and I don't want everyone to understand that this was the standard for studies, but it helps kind of alleviate or remove some of the barriers or some of the concerns that people may have when they're often asked to participate in studies.
Do you see this as a trust building effort?
Yes, absolutely. What we want to do is develop a community, a network community where there is trust among the provider, the researcher, and the patient. And to do that is to provide opportunities for people to participate in research on a community-wide level where it is not too invasive for that particular group, and starting there to help understand the question of why. And most of the time people pour in, it pours in. More people want to participate and to join and to do, especially studies like this, where you're trying to understand, is there a genetic connection to the Parkinson's disease? And how does that affect your family, your individual? So it doesn't just help understanding the why on a small micro level, but also on a macro community level as well.
I imagine that increasing the inclusion and accessibility for this trial will not only help it generate more robust data in terms of having that more diverse participant population, but it might also help future clinical trials in having built that trust between the researchers and the community.
Yes, absolutely. And in addition to this, we get the opportunity to do outreach and to have conversations about what Parkinson's disease is and the importance of it, and helping remove some of those barriers or thoughts that is just associated with old age or something of that nature. So in addition to being able to participate and be a part of research, you also learn about Parkinson's disease with respect to our outreach and the support groups.
Do you anticipate that PD generation might change diagnosis and treatment for Parkinson's disease through genetic counseling?
Yes, that is the question that we're asking ourselves. Once we have a better understanding of the dominant gene within the population, then how do we use this with regards to decision making regarding future participation in clinical trials, medications, therapy, deep brain stimulation, and gene therapy? That's the one that everyone's looking at, right? There are additional studies looking at gene therapy or treatment for people with a certain type of Parkinson's disease associated with a genetic cause. So I definitely think that genetic testing and the data it generates is a very powerful tool to uncover biological pathways that cause Parkinson's disease, and understanding can lead to advances in research, improved treatments, and care for all people with Parkinson's. By including representation among the Black community in the study, we're hoping it will advance scientists' understanding of how the disease specifically affects this population and which treatments are most effective. With this information, researchers can identify and develop new treatments and medications that better serve the unique needs of the Black and African American community.
Thank you so much for joining us, Dr. Branson. It's very exciting thinking about the way things could go in the future with genetic counseling and testing, and also how your work might improve recruitment efforts for future clinical studies.
Thank you.
Did you want to make any other comments before we finish up?
People can still participate. The people who self-identify as Black or African American, we would love for you to join the PD generation study. You can reach out to our institution, Morehouse School of Medicine, directly in Atlanta, Georgia, and we will connect you with our coordinators.
Excellent. Thank you.
Thank you to Dr. Chantale Branson for sharing her knowledge with our listeners in this episode of Amplifying the Patient Journey. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the neurology field.